Hello and welcome. I'm Marsha Mott, the coordinator for UF Health Wellness University. Today's webinar is about herniated discs. 80% of adults experience back or neck pain at some point in their life, and finding relief is a challenge. With so many factors at play, diagnosing and treating back and neck pain often needs the perspective of multiple spine specialists. And that's where our speaker, Dr. Matthew Decker, comes into play. Dr. Decker is a member of the UF Health Comprehensive Spine Center. Shortly after high school, Dr. Decker enlisted in the United States Army, where he served as a respiratory therapist. He then went on to graduate from the University of Maryland and later completed his medical degree and master's in public health from New York Medical College. He then completed a neurosurgical residency at the University of Florida and joined the faculty in 2020. If you have questions for Dr. Decker during the webinar, you can submit written questions anytime using the Q&A button at the bottom of the screen. At the end of the presentation, I will read your question out loud anonymously. I will only be accepting written questions, and I will try to get through as many questions as possible. Dr. Decker, I'm going to go ahead and get ready to turn over to you now. Thank you.
Thank you. There we go. Is this being seen?
Yeah, everything looks great.
Great. Thank you. Hello, and thank you for joining me today. I'm Matthew Decker, an assistant professor for the Lillian S. Wells Department of Neurosurgery at the University of Florida. I'm a practicing neurosurgeon with an emphasis on treating spine-related diseases. In this discussion, I will be talking about lumbar disc disease. This talk is being presented without any conflicts of interest, and I have no financial disclosures. In today's presentation, I will go over normal anatomy and function of an intervertebral disc, pathologic states of intervertebral discs, including symptoms, treatment options on patients with intervertebral disc pathology, particularly those that I offer. What is an intervertebral disc? First, I'll start with some basic spinal anatomy. The human spine is composed of 5 bony spinal segments: cervical, thoracic, lumbar, sacral, and the coccyx. Let's discuss some anatomic features of vertebral bones that will be important in this talk. The spinous process is a prominent part of the vertebrae that projects backwards. In fact, in most people, if you feel along the middle of your back, you will feel a series of bumps going up and down the spine. Those bumps are your spinous process. The vertebral body is the bulk of the vertebrae, which makes contact with the intervertebral disc. The facets, or joints, are located on each side of the back and allow for mobility of the spine. The central canal is a canal formed by the vertebrae. In the cervical and thoracic spine, the spinal cord is located within the central canal. As the spinal cord ends in the upper part of the lumbar spine, spinal nerves travel through the central canal. Lastly, the foramen, meaning hole or opening, is an opening on each side of the vertebrae, and at most spinal levels, a single spinal nerve leaves the spine at this location. For most of the cervical and all of the thoracic lumbar spine, 2 vertebral bodies are separated by the intervertebral disc. Here, I want to point out the relationship of the intervertebral disc and the intervertebral foramen and central canal, as the relationship between the discs and these structures play a role in part of the symptoms a patient experiences with disc disease. The lateral part, or the part off to the side of the disc, composes the front border of the intervertebral foramen, which again is the opening for a spinal nerve to leave the spine. The midline, or middle portion of the disc, composes the front border of the central canal. The discs have 3 main components: a tough fibrous outer layer, the annulus fibrosus, a soft inner layer called the nucleus pulposus, and a third cartilaginous layer that contacts the vertebral bodies. I'll be discussing the properties of the annulus fibrosus and the nucleus pulposus as they relate to disc pathology. On the spine model on the left, you can see that the annulus because it forms a ring around the disc space. Here. On the spine model on the right, you can see the annulus forming a ring around the outer edge, while the nucleus forms the inner circular area. Let's look at the properties of the annulus fibrosus. It's composed of several layers of concentric rings of tissue made up of collagen and elastic proteins. In each layer, the annulus fibrosus is oriented in different directions, which allows the disc to be stretched and moved in different angles while maintaining its overall shape. The annulus fibrosus spans from one vertebral body to the adjacent one. It helps to contain the nucleus pulposus in situations where the discs are under compression, such as when someone is sitting or standing upright. The nucleus pulposus is the inner layer of the intervertebral disc that is more gel-like than the annulus fibrosus. It is made up of proteins and sugar molecules that have a high affinity to water, resulting in absorption of water into the pulposus. In fact, in a non-degenerative adult disc, about 80% of the nucleus is water. As a result, the nucleus pulposus acts like a shock absorber to compressive forces that occur when someone goes from laying down to sitting or even standing upright. Now that we have an understanding of some of the anatomy and normal function of the lumbar intervertebral disc, let's discuss what happens when there's pathology or disease of the lumbar spine. We'll call this process degenerative disc disease. And as the slide indicates, this phrase is an umbrella term for several specific changes of an intervertebral disc. If you've read an MRI report of the lumbar spine, you may have seen some of these words to describe the changes seen on the MRI. While I won't be going over each word individually, I am going to discuss the collective findings that lead to degenerative disc disease and the symptoms one can have. Degenerative disc disease is a phrase that describes changes seen in the intervertebral disc with aging. And what I'd like to point out before going too far is that degenerative disc disease, unfortunately, is a natural process, something that everyone will experience. In fact, radiologic evidence of degeneration can start in early adulthood, even without having symptoms. And MRI findings of degenerative disease doesn't necessarily correlate with someone's likelihood of having symptoms or even the severity of those symptoms. Typical presenting symptom for degenerative disc disease is low back pain, followed by radiating leg pain, numbness, and weakness. So why do intervertebral discs degenerate? Well, there are several factors, and three in particular are anatomic reasons, genetic factors, and environmental factors. First, from an anatomic standpoint, the intervertebral disc doesn't have any blood vessels coursing through the disc, which is vastly different than other organs like bones, your stomach, or even your brain. As a result, most of the blood flow, nutrients, and even oxygen exchange takes place through diffusion from neighboring vertebral bodies. Because of this lack of direct delivery of nutrients and blood, the disc space becomes vulnerable when there are changes in the small blood vessels and the ends of the vertebral bodies that often occurs as people age. This leads to a change in the actual composition of the disc, resulting in fewer molecules that keep the disc hydrated, which then leads to changes that can weaken or stiffen the disc. Additionally, there have been some studies that evaluate changes in the intervertebral disc in identical twins. The general consensus of these studies suggests that variable changes seen with age relate largely to a genetic predisposition rather than lifestyle or environmental factors. This indicates that a significant portion of degeneration is due to your genes, less likely from correctable environmental factors. However, although those twin studies suggest a high genetic component, there is one major environmental factor that does play a role, and that's smoking. Smoking and nicotine use cause body-wide changes in very small blood vessels. These changes lead to a decrease in nutrition and oxygen delivery to the disc space, further contributing to the degeneration. And in keeping with other degenerative pathologic process, smoking cessation is a modifiable risk factor that helps slow the degenerative process. Lastly, there have been several observational studies that attempt to associate certain activities with increased disc space degeneration. The overall suggestion from these studies suggests that only a modest effect of primarily either highly sedentary or extreme activity leads to increased degeneration. Again, multiple different terms to describe disc degeneration. Let's look at some basic degenerative disc disease findings in more detail. First, I'll go over a process where disc material moves into a location where it should not be. This can be referred to as many different things, such as disc bulge, protrusion, herniation, extrusion, sequestration. Again, the main point is that these terms all refer to disc material that is moved out from its normal location. These terms can refer to an acute process or a more chronic process. Duration of symptoms usually helps with this determination. And in general, symptoms that have been persistent for, say, longer than 6 to 8 weeks can be referred to as a more chronic process. Although these findings may be on an MRI report, it doesn't necessarily mean patients are experiencing symptoms. However, in patients who do develop symptoms, the symptoms can often be localized based on the location of where the abnormal disc material is located. For example, a central herniation can affect all the nerves passing through the spine and cause pain in the low back and in both legs. Lateral recess herniations typically contact the next vertebral segment nerve as it makes its way to leave the spine, often producing one-sided leg symptoms. While foraminal or far lateral disc herniations will typically affect the current level nerve as it is leaving or has already left the spine. While these locations help physicians understand a patient's symptom, they also play a role in determining a surgical approach if the patient is deemed to be a surgical candidate. In the last slide, I spoke about pathologic conditions where disc material moves out of the disc space. However, pathologic changes can occur within the disc space that can also have an effect on other parts of the spine and nerves. The bulk of the inside of the disc space is made from molecules that love water. As degeneration takes place, the disc space loses their ability to hold on to water. This causes the disc space this causes dehydration. This dehydration causes the disc space to lose its cushioning effect, leading to a loss of disc height. Because of the changes within the disc space, the lack of cushioning and the decrease in disc height, additional stress is placed on other components of the spine, such as the connecting ligaments and the facets or the joints in the back. This all leads to additional stress, resulting in arthritic changes of the spine. These changes can eventually lead to symptoms of pain and nerve compression, as is evident by the top foramen in a healthy disc space having a large opening, and the bottom foramen being a degenerative disc space having a narrow foramen where the nerve is leaving the spine. Now that you have a basic understanding of some of the degenerative process of the intervertebral disc, I'm going to discuss symptoms. Obviously, the first symptom you may think about is pain. As a provider, I want to know if it's back pain, leg pain, or a combination of both, as this can have implications of what pathology is going on and how I think it should best be handled. Usually there's some component of both back and leg pain, but differentiating the severity and type of pain can be helpful. First, let's talk about low back pain. Unfortunately, low back pain is extremely common to humans. As has already been mentioned, up to 80% of the population will experience some form of low back pain during their lifetime. Additionally, at any point in time, around 30% of the population is currently experiencing low back pain. Fortunately, most of these acute episodes of low back pain, having started days or weeks ago, usually resolve with conservative treatment. Unfortunately, there is a high rate of recurrence of low back pain. Leg pain, on the other hand, is typically specific to nerve roots. Each spinal level provides sensation or pain perception to a defined location on the body. This is referred to as a dermatome. While there can be some variation and overlap from adjacent nerves, these dermatomes usually correlate with a specific nerve and are helpful in terms of determining what spinal level is being affected. Patients will typically describe their leg pain as radiating up or down the leg and describe it as sharp, stabbing, or even electrical feeling. Typically, leg pain is worsened by certain activities. For some, it could be standing or walking. For others, it could be sitting or bending forward. But it all relates to the nerve being stretched or being active. In addition to pain, patients will also report altered sensation like numbness or tingling. Typically, these people associate the sensation as if their legs were falling asleep. These sensations also correspond to the same dermatome. Usually, a patient's main and only issue is pain. However, functional weakness can also occur. Similar to nerves providing sensation to specific parts of the skin, nerves also provide function to specific muscles. The layout of this is called a myotome. In the lumbar spine, there are certain muscle functions that doctors will assess to see if there is weakness and to help localize which nerve is being affected. Typically, the more common deficits will be of those, the 3-starred levels here. Someone having a foot drop from L4 weakness, or someone having some foot weakness from L5, or someone having issues pushing down on their step from S1 weakness. A majority of the points I've discussed so far are due to degenerative changes. However, there are some acute findings that, should someone develop, do require emergency evaluation. In the lumbar spine, an acute condition that needs prompt evaluation and possibly surgery is a constellation of symptoms referred to as cauda equina syndrome. The cauda equina is a Latin medical term for the collection of nerves after the spinal cord ends within the spinal canal of the lumbar spine. The constellation of symptoms are new groin and leg numbness, typically referred to as saddle anesthesia. It's the part that is sitting down, you can't feel. New paralysis of the legs and feet, and an inability to void, which typically presents as someone having a full bladder, resulting in incontinence. While cauda equina syndrome is not common, having all 3 of these symptoms is concerning and constitutes a medical emergency, as prompt surgery may be needed to help with regaining any lost neurologic function. Now that we've reviewed intervertebral discs, normal anatomy and function, how they can cause issues, and the symptoms one may experience, I'm going to discuss some treatment options. There are several surgical and non-surgical treatment options. Some options may or may not be suitable for a person and may or may not be effective. The particular treatment option performed will depend mostly on the duration of symptoms, specifics of pain, and if there are any deficits like weakness. Some non-surgical options include medications. Some medications include anti-inflammatories like Advil or ibuprofen, or very effective non-prescription medications for treatment of acute and chronic low back pain. Unfortunately, they can have serious side effects if taken at high doses for a prolonged duration, or in those who have other medical problems. Muscle relaxants and opioids can be effective for severe pain or muscle spasm. However, their use should be really limited to acute settings, as meta-analyses do suggest no significant benefit from long-term use, coupled with their potential for addictiveness and their side effects. Gabapentin, or more broadly a neuropathic medication, can be helpful in treating radiating pain. And a short course of steroids can be effective in those with acute radiating leg pain. Long-term use is not recommended because of their significant side effects as well. Therapies is another non-surgical treatment option, and these consist of several things. It is a general consensus that staying active is better than having bed rest, and a tailored multidisciplinary physical therapy program educating patients about psychological effects of pain, improving core muscle strength, and improving conditioning has been demonstrated to be useful in reducing acute and chronic low back pain. Massage therapy, chiropractic therapy, and transcutaneous stimulation are other forms of manual therapy that, while in large studies haven't shown to have significant long-term relief, can be very effective in certain individuals who do respond to these treatments. Lastly, there are other non-surgical pain intervention procedures. Epidurals, which or little shots into the lumbar spine, can be very effective in treating pain from a short-term perspective. Nerve injections at specific levels to treat radiating pain, again, can be very effective when the patient's history, exam, and radiologic findings correlate with one spinal level. And ablations, or heating up tissue, is the idea that small nerve pain fibers are being disrupted and help reduce low back pain. Now I will discuss some surgical options. Because there are a variety of surgical approaches and styles, I'm going to discuss my general approach to a patient and procedures that I perform. There are some considerations that I always take into account when I first meet a new patient. First, if there are any functional neurologic deficits such as weakness, bowel or bladder dysfunction, then surgery may be needed in order to preserve that function and allow for any return of loss of function. Second, I consider the duration of symptoms. For a patient without any weakness or bowel or bladder issues, and they have acute onset pain, they should generally have tried a trial of non-surgical treatment to see if the pain improves. In patients with chronic pain, I also would like for patients to have undergone non-surgical treatment options prior to even offering surgery. And for any surgery to be successful, a patient's history, physical exam, and radiologic findings should all point to the same pathology. Lastly, I also evaluate patients to ensure they don't have significant medical issues that make surgery too risky. After going through that list of considerations, my thought process in surgery is identifying what is causing symptoms that needs to be addressed. And broadly speaking, in the lumbar spine, I have two main categories: nerve decompression and spine stabilization. For nerve decompression, this can be achieved essentially by two methods. The first, by directly finding a compressive lesion, such as a disc herniation, and removing the disc, inspecting the nerve, and ensuring that the nerve has no further compression. Here you can see a spinal nerve is being retracted and protected, while behind it is a disc herniation that is about to be removed. After it's been removed, the disc herniation is no longer contacting the nerve, and the nerve is free, no longer compressed. The second method is by indirectly opening up the pathways a nerve travels, such as increasing disc height in disc spaces that have disc collapse. This left-hand picture shows that a disc space has collapsed and is causing compression of this nerve as it's leaving the spine. Here on the right, it shows that the foramen has been opened up as a result of taking out the disc and inserting this taller graft, restoring the disc space height and releasing compression of the nerve. And while this picture shows that this was achieved through a lateral or a side approach, the same objective can be achieved by going from the front or from the back. After considering nerve decompression, I then consider if there is a need for spine stabilization or a fusion. Not every patient that needs nerve decompression needs a fusion. For the purposes of lumbar disc disease, in considering spinal stabilization, there should be evidence of instability, indicating abnormal motion due to degenerative discs. For example, in the image on the far left is an X-ray with a patient laying down. You can see at the L4 and L5 vertebral space, there is a slight relative motion of L4 forward relative to L5. When the patient stands up, we can see that that space increases, indicating that there is abnormal motion when the patient stands upright. This abnormal motion is due to some form of instability. The second reason why a patient may need stabilization would be because the procedure to decompress the nerve would cause over instability, and so I would choose to stabilize the patient while doing the decompression. For example, in this patient, there was a large disc herniation in the foramen or the window where the right L4 nerve root was leaving the spine. The left-hand picture shows that the left L4 nerve root is leaving the spine without being compressed. That's the nerve root right here. On the right-hand side, we can see that there was a very large disc herniation within the foramen, obstructing the view of the right L4 nerve root. In order to get this disc out, it required complete removal of the joint behind the nerve and removal of that disc herniation, which leads to instability. Unless stabilized during surgery, the patient would most certainly develop movement at that level, like was demonstrated on the last patient. A few final considerations regarding how I approach surgical options with my patients. It's almost inevitable that an MRI or X-ray will show some form of degenerative changes at multiple levels of the spine. I aim to address what is actually causing the patient's symptoms and not necessarily what's seen on the MRI. I also value patient input. Sometimes there is more than one surgical way to address symptoms. And when that's the case, it's important to have a discussion about the different approaches and discuss which one is appropriate for that patient. Lastly, surgery is a team sport in more than one way. Between the patient and surgeon, it requires 100% commitment on both ends. As the patient, you are asking your surgeon to make the best judgment and stay focused while taking care of you. As a surgeon, I ask my patients to help me by making lifestyle changes such as smoking cessation, optimizing other medical conditions, or undergoing physical activity before and after surgery. All of this to improve their surgical outcome. If you have any type of spine-related issue that you would like to have to be assessed, please contact our UF Health Comprehensive Spine Center. It is a multidisciplinary group of spine surgeons, pain management physicians, and physiatrists, all working together to solve spinal pain and functional issues. Thank you.
All right. Thank you so much for doing that presentation. I appreciate that. We're going to go ahead and take some questions right now.
Okay.
And we'll get started with the first one. I just want to make sure. Can you see me on camera?
Yes.
Okay. I've disappeared off my own screen, but that's all right. What do you think about using an incline table to stretch the spine on a regular basis?
Yeah, so that can be referred to as cervical traction lumbar traction, I misspoke. The idea being that you're taking the pressure off the spine by increasing the space of the disc space itself and reducing some of the pressure. I view that as if it's something that helps this particular individual, I don't see any harm in doing that, especially if it helps. It's sort of like a lot of other treatment options. It may not be particularly effective for everyone, but if you find benefit, there's probably no harm in doing it.
Okay. Thank you. How many nerve injections can you have, and over what period of time can you have them?
Yeah, I would say there's probably no absolute number of maximum you can have. It's more of if you continue to get them and not getting the effect that you're wanting, then it may not be the right treatment option for you. Some of the amount that you can have is sometimes limited by payers or insurance approval. They generally have a limit. But usually if you're requiring very frequent nerve injections just for pain, it may not be the right treatment modality for you.
Okay. Next question. Oh, and also you can turn off your screen share when you get a second.
Sure, sorry.
Next question. What about stem cell treatments for chronic low back pain?
Yeah, that's a question that I've been asked before from some of my other patients, and honestly, I don't think there's a lot of good data on that, and so I'm not really the best person to answer that, nor do I know if it's an appropriate treatment option. Maybe as time evolves, we will have the science that proves that it's effective, but at this time, I just don't know if it is.
No problem. That's a good answer too. So I think people always appreciate when they have a doctor says, that's just not my area of expertise. So that's great. Can you comment on cervical disc issues and how successful surgery can be for those?
For cervical spine, very similar to success in the lumbar spine. Obviously in the cervical spine, you're more concerned about the spinal cord and less of the spinal nerves. But certainly if someone has a cervical disc disease that's pushing pressure on the cervical spine, the cervical spinal cord, it can be a very effective treatment options for moving pressure off the nerves there.
Okay, thank you. Can you answer a question about, we have one that says, can you be treated by a chiropractor when you have herniated disc, and is it beneficial?
So the treatment would be dependent upon the chiropractor actually doing it, but some people do find benefit and pain relief from chiropractic therapy. I have multiple patients that I've tried in the past and they continue to do it, and if it's no longer effective, then that's when they seek out another opinion. So it's sort of the same thing with the tilt tables. If it's effective for an individual, I highly recommend it.
Okay. And can a herniated disc contribute to sciatic pain or symptoms like numbing, tingling, and balance?
Yeah, so sciatic pain, I didn't specifically make that mention, but that's that pain referring down the legs. When we say radiating pain, people commonly refer to as sciatic pain, as the sciatic nerve is a constellation of nerves. As the nerves leave the spine, they become one big nerve. And so yes, that's the same thing as radiating pain, the radiating pain I was describing in the presentation.
Okay. Thank you. So I'm going to ask a question about artificial discs. Are artificial discs available yet? Or do they still use a sponge with a special coating?
So there are, we wouldn't call it artificial disc, we call it a total disc replacement, where it's not the actual disc itself, but is a mechanical device that tries to mimic the function of a disc, and that it still provides mobility. That's available for the cervical and lumbar spine. Unfortunately, for both the cervical and lumbar spine, the indications tend to be kind of narrow. And so most people with degenerative disease of the lumbar spine may not actually have a good indication for a total disc replacement.
Okay, and so kind of a follow-up question to that about disc replacement. Will the replacement stay in place for forever? And is there like a fusion with rods and screws required with that?
Yeah, so if you're getting a total disc replacement, the idea behind that is to maintain the motion at that disc space. And so the device that is made for that tends to maintain the motion. And so there's no rods and screws per se with that. The idea is that it doesn't fuse, but in patients it can still fuse even without the rods and screws. Fusion surgeries are ones where we intentionally put rods and screws in to prevent abnormal or any motion in the spine, so that way the bones do grow together, and that's different than a total disc replacement.
Okay. I have a question. Someone writes in and says, my back pain began when I was 32. Now I'm 69, and it's been recommended that I get a multi-level fusion. I've pretty much tried all treatments. However, this procedure really scares me. If I do the surgery, would I be able to do all my activities that I love, like hiking, skiing, and biking?
Yeah, so certainly people that undergo lumbar fusions can still be active. Obviously, the extent of the fusion may limit some motion in your back, but it certainly should not prevent you from going hiking, that sort of thing. Some more of the extreme sports may be more of a patient-specific answer in terms of what actually was done and what activities they're looking to do.
Okay. Thank you. What about electrical stimulation? Is there any help with that, or any hope for that, maybe helping with degenerative disc issues?
Yeah, so one of the therapies I briefly mentioned was the transcutaneous stimulation. That's a form of electrical stimulation where you put pads on the skin, and the goal is that you create a sensation that the body interprets as a sensation to help reduce the pain. And that's an external device that one can use. There's also a device called a spinal cord stimulator. I didn't speak about that. I don't perform those. We have pain management doctors here at UF that do perform those. And that's an internal device where it mimics the same thing. It produces a sensation such that your body doesn't interpret the pain the same way. And that's certainly effective in certain populations.
Okay. Someone writes in, how important is it to lose weight before undergoing nerve decompression stabilization?
Yeah. So certainly if you're in a higher risk or higher, we call body mass index, such as obesity, losing weight prior to surgery, certainly makes a benefit from a surgical standpoint, as well as a post-op healing standpoint, as well as just general health improvements after surgery. It's always recommended to be a healthy BMI, but sometimes it's difficult to do.
Okay. Can you talk a little bit more about sciatic nerve pain? What causes it, and where does it come from in the spine?
Yep, the sciatic nerve pain is due to the irritated nerves as they are leaving the spine. As I discussed in the presentation, a disc herniation or movement outside of the disc space can make contact with the nerve and irritate it. Other things such as arthritis of the bones or overgrowth of the bones and joints can also pinch the nerve and cause that sciatic type pain down the leg. And then any type of prior injury, if you've had prior surgery, there could be an injury to a nerve as it's leaving the spine and result in permanent pain in a similar distribution.
Okay, we got a question about exercise. Can you recommend any exercise for herniated disc, or should that be left up to a physical therapist?
Yeah, I typically leave that up to a physical therapist. In general, walking isn't always a great option for people with any type of back pathology, and so that's a first line recommendation. But for specific therapies, I generally leave that for a physical therapist to evaluate you for.
Yeah. All right, those physical therapists, they can do wonders, can't they? Next question, for C-spine, do you use artificial disc material or insert a disc to maintain movement in the C-spine?
Yeah, so for a artificial disc replacement of the cervical spine, it's not actual disc material. It's a metal object that metal and plastic object that functions to mimic motion of the cervical spine. I think that's what they were looking for on that.
I think so, yeah. Okay. This is kind of a long question, so I'm going to read through it. After years of low back pain when standing for extended period of time, I've experienced some acute pain lasting for a couple days, followed by maybe a month of recovery. I had an MRI and was told there's not a surgical need. Now I've been referred to an interventional pain doctor for a review. Does this process make sense, or am I missing something here?
That process makes total sense.
Okay.
Everyone who has back pain has back pain. It just unfortunately may not be a surgical treatment options that will be effective at relieving the back pain. Seeing a pain management doctor is a very common practice, even for those that eventually need surgery. And so that's a pretty good recommendation. I'll follow up with that.
Okay. What's the recovery time for a spinal surgery?
So in general, it kind of varies on the extent of spinal surgery. Generally, there's a couple weeks of wound healing or making sure the incision closes completely. And usually another period of around 6 to 8 weeks, where in general we want people active, but no heavy lifting, extreme bending, or doing anything that may kind of reverse what was done on the inside. And then depending if it was a fusion or not, there may be an additional longer kind of healing process. And that really depends on the specific surgery underwent.
Okay, thank you. Is there any holistic cures for herniated discs, or are medications and surgery really the only measures for relief?
So the treatment, I think what the person's asking is there any holistic treatment for the pain? And so yes, certainly there's other options that aren't medications or surgeries that some people find to be effective for them. And again, it's kind of a trial and error to figure out what's effective for treating the pain. As far as holistic to remove a herniated disc, I'm not aware of any.
Yeah, that would be miraculous, huh? So another question we have says, I have a C6, C7 herniation. I'm very functional, young, and I manage with injections and massage and PT. What could my long-term expectations be for surgery?
Yeah,
like how long maybe could I keep going without having to have surgery, or is it inevitable?
Yeah, one big differentiating factor in the cervical spine, and not knowing kind of the specifics of it, would be if the person develops any spinal cord compression. If it's purely just arm pain at one specific level and it's not causing weakness or spinal cord issues, then treating it conservatively with not doing surgery is a very reasonable option. And it really depends on how long the person is willing to undergo all of these conservative treatment options before the person says, I've had enough, I'm ready to undergo surgery. Just because they have an issue right now doesn't necessarily mean that it will be a permanent issue. Again, a lot of times an acute issue may improve with time and may not even need surgery. And so it's hard to predict what's the likelihood someone will or will not need surgery.
Okay. Someone writes in, they want to know if you or maybe even any other members on the team promote a special intervention that's not performed by other surgeons at UF or in the area. Like, is there anything special that the Comprehensive Spine Center or that you do that maybe is not offered for, for a very far distance?
Right. I think one of the benefits of the Comprehensive Spine Center is that we have all our physicians work closely together, surgeons and non-surgeons alike. Very commonly, I will see patients in clinic where I would like for them to have some sort of physical therapy or some sort of pain intervention. And during the clinic visit, I go and talk to my colleague, tell them the specifics about the patient, and they actually go see the patient right then and there. We also have at UF Health a comprehensive spine meeting where we talk about all of our complex patients between all the surgeons, pain interventionists, kind of get a big gathering of opinions. And so I think that's a lot of value added by our spine center that you may not get at another hospital that doesn't have everyone working together.
Okay, and what other members are a part of the spine center team?
We have pain interventionists, which are generally an anesthesia provider that does various kind of using X-ray guidance. They do various pain interventions. We have physical therapists. We have physiatrists, which are people who work with physical therapy to improve patients' pain or function.
Okay, great. Another question that came in is, are there surgical options for facet joint arthritis?
There are surgical options, yes. A lot of the concepts that I was talking about with degenerative disc disease also play in, leading to either a result of or contribute to facet disease as well. And so some of the procedures that I discussed about removing pressure off a nerve or even stabilizing a spine is a very similar process that one would go through in terms of removing abnormal facets to open up the spinal canal or open up a spinal foramen.
Okay.
There are also, there are also non-surgical interventions such as the ablations. Facet ablations are very effective for people that have facet pain.
Okay. Another question that came in is, can you suggest what might prevent dehydration of your discs?
Yeah, that is I think a big question that a lot of people would like to know the answer to. I don't know if we can necessarily prevent that. Unfortunately, I think it's a lot of it's a natural process that is out of our control.
Okay. And then another question that says, someone in my family's been struggling with lumbar back pain for several months, had a couple injections. They have herniated discs and some arthritis. Why do injections work for some people and not others?
Yeah, pain is a very complex medical issue that comes up, and it's difficult because sometimes the fact that pain fibers are in multiple different locations within the spine makes it very hard to target maybe one specific area that it's causing pain, especially in someone that has multi-level or more than one spot within their spine arthritis. And so it can be very difficult to actually effectively get rid of pain completely.
All right. And then that person also kind of followed up and said, is physical therapy and pain management really a reasonable treatment for a lot of people?
It is, yeah. It's probably the first line treatment that is is recommended in people who are just having pain without any neurologic dysfunction. Like I said, a lot of times some acute exacerbation of pain will likely improve with either time or with some of the interventions. And it's certainly safer to undergo physical therapy or a pain injection if you're going to if you may get better from it than to undergo a surgery that does have risk associated with it.
Sure, thank you. And then one of our last questions we have here is, someone asked, where is the Comprehensive Spine Center located at UF Health?
Yeah, so the actual physical address is 1505 Southwest Archer Road, Gainesville, Florida. The UF Health complex consists of 3 hospitals, and the Comprehensive Spine Center is in the Heart, Cardiovascular, Neuromuscular Hospital, which is the brand new hospital.
Okay,
I
great.
don't know if you have any of that information on the.
Yeah, it'll pop up on a slide here in a minute, and then also in a follow-up email if people that had registered to attend, it'll give them that information of where they can find out more information about it. But so that's all the questions that we have for today. Anything else you'd like to add for us?
For the person who is wanting to know what the Spine Center is, our number to our Comprehensive Spine Center is 352-265-SPNE. That's 7763. You can call that number and it goes directly to one of our message handlers at the Comprehensive Spine Center itself, and we will try to plug you into the right people.
All right. Well, I thank you so much for the time that you've taken to give us this presentation today, and taking all the questions that we had as well. And I appreciate it. And thank you so much.
Well, thank you very much. And thank you for everyone for attending.
Thank you.